Hello friends, in this small discussion in this clinical Thursday, I am here to discuss one of the most important, very commonly asked and most relevant topic in anesthesia point of view. This is about ventilator. Of late we have seen INICT questions coming from ventilator as well. So I thought we will just discuss one question and based on which we will plan the ventilator management, so that at the end of the session you can ask me doubts regarding this, your questions on this, and also the various aspects which you get questions will also be cleared in this small discussion. Okay, this is the background. So without wasting much time, we will just see the question which has come up. We have discussed in our recall, but I thought to have a basic idea how the question comes, I will just discuss this as a background question. Okay. Now see, a 55-year-old man with weight of 70 kg admitted with acute pancreatitis related complication, intubated on ventilator with following settings. They have given the settings. We will come back to the settings. Now what is the next step of management? That is a question. Now to start with, we all should know how to set a ventilator. Now for that we need few parameters to set. For example, I want the patient weight. So the first topic which we will be discussing is setting up a ventilator. Okay. Now of which I want the weight of the patient. This is the first concern. Now regarding the weight, I will be looking at the ideal body weight, not the actual body weight. Suppose you want to ventilate a patient who is 100 kg, you don't calculate the 100 kg. We will only consider the ideal body weight for this patient. Okay. So in this, for example, if a patient is in this scenario or whom we are discussing, the patient is 70 kg. So depending upon that, which probably is the ideal body weight which they have given. Okay. So if most of the entrance question they give the ideal body weight, you don't have to bother, but for practical purposes you will have to calculate the ideal body weight for that matter. Now anyway, coming back to the weight, that is an important point which you should remember. Always think about not to take the actual body weight if it is an obese individual for particular, because you will end up with large tidal volumes which can cause barotrauma. Now having said that, the next point is about the tidal volume. Tidal volume, the original concept was to give 5 to 10 ml per kg. It was the initial thing to start with. Now we are actually coming down. Now it is actually 5 to 8 ml per kg is what is needed for ventilating. We don't do a hyperventilation. So that is one important point which you need to remember. Next, so tidal volume is set. The third point is regarding the respiratory rate. So what is in a respiratory rate? Normally we keep it anything between 12 to 16. Okay, if you want a single number, consider it as 14. This varies depending upon the kind of patient whom you are planning to ventilate. See, for example, if you are ventilating a COPD patient, or if you are ventilating a patient with bronchial asthma, or who has got a bronchoconstriction or take longer time for the air to move out, then you should reduce the respiratory rate. Okay, so you can keep it as 12 in those scenarios. COPD, bronchial asthma, reduce the respiratory rate. Now coming to the next one, this can be done by IE ratio. The normal IE ratio is 1:2. It can vary up to 1:4. Very rarely you can also go with inverse ratio ventilation where it is actually 2:1, or reverse the rate. Normally inspiration is short and expiration is prolonged, and at times when you go with inverse ratio ventilation, as in case of severe ARDS, you think about inverse ratio ventilation, prone ventilation, etc., which is usually an advanced ventilatory setting. normally for entrance purpose, they don't ask much questions on IE ratio. So we don't elaborate on that. Just remember, you need to have an IE ratio also into mind when you think about setting a ventilator. So and most commonly it is 1:2. The next point is PEEP, which is positive end expiratory pressure. We will have to discuss in detail about PEEP in our subsequent slide, because PEEP is the area where you get questioned. Positive end expiratory pressure or PEEP is the pressure which is left behind after exhalation. You know, inspiration there should be a positive pressure, isn't it? Then during expiration the pressure has to come out, then only the air will go out. But even when the exhalation is going on, you don't completely empty the alveoli. There will be some amount of air left over, isn't it? This some amount of air sets in a bit amount of pressure, which is called the end expiratory pressure. So to prevent the collapse of alveoli after becoming big or inhalation, you always maintain some amount of pressure within the alveoli. This is called inspiratory or the positive end expiratory pressure, the pressure which is left behind at the end of expiration. PEEP. Normally, when a patient having an artificial airway or an endotracheal tube, a minimum amount of PEEP which you should keep to tide over this is 5. So to remain or to learn, study it as 5 to 8 millimeters of what is the PEEP which is normally encountered or normally kept for any patient to start with ventilation. We will study this. Now, other than this, we have one more thing which is called pressure support. Pressure support is the extra pressure which you give to inflate the lung. When the patient is taking in inspiration, normally the ventilator will give only oxygen. But along with that, you give some extra pressure, say to start with anything between 10 to 15. At times you will have to give more than that, but to learn 10 is a good number to learn. So pressure support of 10 is kept. This actually, the advantage being, it reduces the work of breathing. So the work of breathing is reduced with pressure support. Okay. So pressure support is an integral portion to give some rest to the muscles, okay, and reduce the work of breathing. So this is again another point which you should learn. Next, we should also consider a very important, a salient point which is called FiO2, fraction of inspired oxygen concentration. That means how much amount of oxygen which is given to the patient, how much oxygen you are giving to the patient. This is called FiO2. Normally, when you start or initiate a ventilation, you have to actually keep 100% oxygen for the first time. Then wait for 15 to 20 minutes, take an ABG and find out what is the PaO2. 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 That means amount of oxygen in patient's arterial blood, which should be anything between 100 to 80 to 100 millimeters of mercury. Okay, so this much amount of saturation should be there. And idea, when you start a ventilation, it is 100% or FiO2 of 1 is kept. And then the concept is reduce the FiO2 to the minimum. Okay, reduce the FiO2 to minimum to maintain a PaO2 of anything between 80 to 100. So you remember, oxygen is not a drug for everything, or it is not something which has to be given to any patient as we do in casualty or EMD. It is a drug which has definite concentration to give, definite for particular duration. So it is also problematic, because if you give it in larger volumes or larger concentration for longer duration, it can produce free radicals and cause injury to the lung in a very significant manner. So idea is now to reduce the FiO2 to a patient, which is, or to provide the bare minimum FiO2 needed to maintain a reasonably good PaO2. Okay, so that is the concept of FiO2. This is important and gaining importance in in a day-to-day manner. Now, another point is to set the alarms. Alarms are very important because this is something which always keep you from preventing a barotrauma. Anytime when I put a patient on ventilator, there are various aspects which troubles me, but of which one of the most important thing which I will be bothering is I am not causing a barotrauma to this patient. So for preventing that, I need alarms to be on. Alarm should be there to let me know whether the oxygen concentration is coming down, whether there is any leak in the circuit. In that case, the tidal volume is not properly delivered, whether the pressure support or the total pressure in the airway is going up. For example, if the peak pressure, peak inspiratory or peak expiratory pressure goes up above, or you can remember it as peak pressure in the circuit, anything more than 35 is dangerous for us. 30 is what usually kept, 35 is a bit more high. In that case, anytime you can cause an injury. So these pressures are also important. So I have given you an alarm concept also, and this will help you to set a ventilator. Understood? So all these things, along with this, you should also take care of a few things like humidification or warming up of air, warming of the oxygen provided. Okay, and along with that, we should also make sure that intermittent suctioning is done, proper care of ventilator is done. We will not be discussing about the other aspect like weaning from the ventilator, which is again yet another large topic to discuss, which we may get question. Older question papers had that questions of weaning, but nowadays we don't see much of questions on weaning. But that is also something which you can remember. You can go back to our notes and check. There are areas where weaning has been asked in previous questions. So that these are areas which you should remember in ventilator. Clear? With this idea, two aspects we will discuss. The first aspect we will discuss about PEEP. I told you it is a positive end expiratory pressure. Remember, when an alveoli is being ventilated, there can be few alveoli which actually take part in ventilation, like they inflate very well and take part in ventilation, while there are other alveoli which doesn't take part in ventilation to a significant amount. So whenever the oxygen saturation comes down, one of the method to improve oxygenation is to increase the PEEP. Now when you increase the PEEP, what is the advantage? You can recruit more and more alveoli to take part in respiration, and also to prevent the other alveoli from being collapsed, and also you can overextend the alveoli which are actively taking part. Now see this, when you increase the PEEP, what has happened is the alveoli which was not taking part in ventilation, another alveoli open up. They start taking part in ventilation when the PEEP is applied. So PEEP applied, there is an increase in ventilation. Another alveoli started. This is called recruitment. So I have recruited one more alveoli to take part in ventilation. So more surface is there for exchange, oxygenation improved. At the same time, there is an overdistension of the alveoli which was actually taking part, and which can cause problems. This can cause a rupture of alveoli or a barotrauma of an alveoli. At the same time, it can also collapse the blood vessel which was there, get compressed when the alveoli is expanding. So that is again another problem of increased PEEP. So PEEP is a double-edged sword. It can improve oxygenation, increases the oxygen, but at the same time it can cause some amount of problems like reduction in the blood flow to the lung if it is exceeding more than what is needed. This help us to reach another area, which is a very common area where you get questioned, the side effects of PEEP. So when PEEP increases, as you know, the total pressures of the thoracic cavity increases, which cause reduced venous return. And since there is reduced venous return, there is reduced cardiac output, resulting in many MCQs, resulting in many conditions which will be asked as MCQ, like reduced urine output, reduced GFR, both have been asked. Again, increased PEEP, reduced cardiac, reduced mesenteric blood flow, causing mesenteric ischemia. Again, the blood pressure comes down. And another problem, whenever there is increased thoracic pressure, even which is present even during expiration, the free drainage of the SVC comes down, superior vena cava come down, causing stasis of the blood which was flowing from the head, causing increased ICP. So ICP is increased. ICP is increased. Okay, so now I have given you key points that whenever you increase PEEP in a undetermined or an uncalculated manner, like thinking that I should improve oxygenation, I should recruit more and more alveoli, I keep on increasing the PEEP to 18, 20, 25, etc. It can cause reduction in the venous return, reduction in blood pressure, reduction in cardiac output, reduction in mesenteric blood flow, and reduction in blood pressure, and at the same time it increases the ICP, intracerebral pressure increases. Rest all pressures come down, but ICP increases in increased PEEP. This is one point which you should remember about PEEP. Okay. Apart from that, it can cause barotrauma and de-recruitment, etc. So these are all points which can be asked for you. Okay. Now you should think about how to ventilate an ARDS patient. What are the specialties? ARDS means the patient has got a lung which is gradually damaging. Here 2 points which you should look into consideration. Number 1, the baby lung concept. Okay. And number 2, open lung concept. Open lung concept. Okay. These are the 2 points which you should think about. Now what is baby lung concept? Here we consider this lung which is damaging due to infection with lot of infiltrate. We consider it as a baby lung. We don't want to expand it too much. We don't want to we don't want to cause a barotrauma. So in that case, the tidal volume is reduced. We try to ventilate this patient with a tidal volume of only 5 to 6 ml per kg. This is the baby lung concept. We compensate it by increasing the respiratory rate. Okay, and we also increase the PEEP. We also increase the PEEP by increase the respiratory rate and also by increasing the PEEP. So normally the PEEP which we keep of 5 to 10 can be increased to 15 or 18 millimeters or centimeters of water in case of ARDS. But whatever said and done, it should always be monitored that the peak pressures of the system should not go beyond 30, safe margin, or some books gives it as even 35. So peak pressures has to be kept limited to 30. So this is one concept which you should keep. Now what is open lung concept? Open lung concept is nothing but you are trying to keep all the alveoli open, because in ARDS you know what happens. In ARDS what normally happens is the full alveoli will be filled with debris and there will be lot of fluid here, exchange has come down, and any time when it collapses during a expiration, this may not again inflate back. This may not inflate back. This is prevented by keeping an increased PEEP. And this is, you keep the lung open. This is called open lung concept of ventilation in ARDS patients. So a bit amount of more than what is normally done. A higher PEEP is often welcomed in a case of ARDS. This is what is known as open lung concept in ARDS ventilation. Apart from that, there are many other concepts which are used in ventilating a patient with ARDS, but for an MCQ point of view, for a postgraduate exam, entrance examination point of view, these are the two areas which you should take care into consideration. Okay. So with this, we will go back to our question and see whether we can solve this. See, in a tidal volume, they are given it was 70 kg patient. So 6 ml per kg, it is 420. That is fine. I am okay with this. The respiratory rate is quite high. It is 33. Respiratory rate is related to, by this time, it is elimination of carbon dioxide. So you see, what is a pH? The pH is 7.33. The normal pH is 7.35 to 7.45. So below 7.35 means acidosis. Patient is a bit in acidosis. Okay. Now the cause of acidosis is here that PCO2 is high. Normally is 40. Instead it has gone up to 48. 48. That means patient is having a respiratory acidosis. Now when there is respiratory acidosis, there will be always a compensatory metabolic alkalosis coming in, or a metabolic component will be there causing an increased bicarbonate, which you would have noticed from 22 to 24 of normal, it has gone up to 28. That means body is trying to compensate by producing an alkalosis. Okay. So a respiratory acidosis gradually getting compensated by an increased bicarbonate. Okay, that is the scenario. While the oxygenation is bit more than what is needed. Okay, bit more than what is needed. What we need is only 80 and 100, and whenever a case of ARDS, we can tolerate an amount of hypercarbia, which is known as permissive hypercarbia, which is again another concept which you can add to this, which is known as permissive. The third concept is permissive hypercapnia. Hypercapnia. That means you can add the normal PaCO2 is 40, but even if it becomes anything up to 60, you can tolerate. You can tolerate in such patients. Okay, this is permissive hypercapnia, which is accepted nowadays. So if in ARDS management, so this patient has got respiratory rate of 32, which means the patient is actually trying to eliminate the carbon dioxide by its own mechanism, by which it has increased the respiratory rate, and 32 has come. Now, according to the recent guidelines, whenever the patient has crossed 35, you have to think about supporting this patient. Now, 35 is a number which I am looking at for telling that this patient is going to fatigue and may need ventilatory support soon. But now some books even say that 30 can also be considered as a number. But anyway, in this scenario, patient is reasonably stable and the PEEP is very reasonable to 12. 12 to 14 is okay. And FiO2 is quite high. FiO2 is 0.9, which means that this patient need not have this much of amount of FiO2 because his oxygenation is well above than what is needed. So the first thing which you should do is to reduce the oxygen administered to this patient for fear of oxygen toxicity. Don't worry about the carbon dioxide because the concept of permissive hypercapnia is there. Don't worry about the acidosis there because you treat them with bicarbonate, extrinsic administration of bicarbonate only when the pH is less than 7.3. Below 7.3 only you give bicarbonate. 7.33 is okay, it will compensate itself. Okay. So these are the concepts. So the question was, what was the first step to do? In this concept, the first step is to reduce the oxygen administration which is given to the patient for fear of the hyperoxide or the oxygen free radical which is going to produce and cause further lung injury. So that is a concept. So in this discussion, we have seen the essential parts only of ventilatory management, how to set a ventilator, what are the concepts of ARDS management like the open lung concept, the baby lung concept, the permissive hypercapnia concept, and the problems of hyperoxygenation. Yeah, and then we also have discussed, try to solve the question, what are the initial steps of management, and something about the normal values of ABG, which you should all be knowing. And that is probably what you need to know about a ventilator and the basic settings. I hope it will be some kind of revision or useful to you. And any questions we can discuss, you can get back to the format, you can message us and we will get back to you. Okay. Thank you for your patient hearing.